Welcome to another important topic of the gastrointestinal system. This is a part two. We covered some important primary four gastrointestinal hormone in the previous video. So in this video, we are going to cover the secondary hormones that are motilin, somatostatin, vasoactive intestinal peptide, gastrin releasing peptide, also known as bombesin. Histamine, it is not a hormone, but it is a very important peptide we need to discuss about in the gastrointestinal system, especially in related to acid secretion. And we summarize all these five peptides, secondary hormones in this video. So these first one to three topics we covered in the part 1 video. Right. The learning objectives, we are covering the objective 1. In the objective 1, we covered in the previous video gastrin, secretin, cholecystokinin, gastric inhibitory peptide. In this video, we are going to cover motilin, somatostatin, bombesin, histamine, vasoactive intestinal peptide. Alright, so let us recollect or apply our knowledge of the previous material. So here we have 45-year-old man comes to the urgent care because of the burning and pain in the abdomen past 2 months. The pain is relieved with the meals. A gastric acid secretion test reveals the stomach pH is a 1.2. Normally, the stomach pH is 1.5 to 3.5. So the secretion of which of the following can regulate the hyperacidity noted in this patient? Pause the video and come up with the answer, then we can discuss the correct and incorrect options. Alright, I think you guys got the correct answer. The key findings in this case, what is the key findings? That is the hyperacidity 1.2, right? So that is the key finding. And also the hormones that counter-regulates the gastric acid secretion, it's a mainly secretin, right? So secretin, it is a mainly released from the S cells of the duodenum when the acidic chyme enters, right? So S cells of the duodenum, when the chyme enters to the duodenum, it releases, stimulates the pancreatic bicarbonate, neutralize that acid, right? So especially in this case, the patient, what type of ulcer they have? Because they relieve with the meals, that is the duodenal ulcer, right? So that is the classic for the duodenal. Whenever you take the food, it will subside. And also, how about incorrect options? The gastrin from the G cells, right? So it increases the gastric acid secretion. It can worsen the hyperacidity. How about the histamine? Histamine is a strong stimulator of parietal cells, especially by what type of histamine receptors? H2 receptors, remember, right? So H2 is a GS cyclic AMP. So strong stimulator of parietal cells, H2 receptor mediated. It also increases the acid, right? So it worsens the condition. How about the vagal stimulation? So vagal stimulation means acetylcholine. Acetylcholine increases the acid secretion via acetylcholine muscarinic receptors, and also the vagus releases the gastrin releasing peptide GRP. So that GRP increases the gastrin release, so that increases the acid. So the correct answer is the secretin, the only option reduces the gastric acid secretion and make it the physiological regulator of the hyperacidity that is seen in this case. Alright, so the correct answer is secretin. Right? Alright, so just recap the part 1. So part 1 we cover all these four primary hormones. These primary hormones like how they get these sensing signals. So especially in the gastrointestinal tract, you have two types of signaling mechanisms, right? So one is the neuron, so vagus nerve, right? And hormonal. So the hormone release, like a gastrin and secretin, cholecystokinin, gastric inhibitory peptide, and they binds to target tissue and modulates the gastrointestinal action, right? Or chemical or mechanical. So chemical means all these chemicals like pH changes, right? Or bicarbonate, electrolytes, water, or mechanical. So that means the distension of the gastrointestinal tract that stimulates the peristalsis, right? So we have a neural, hormone, chemical, mechanical signals, so that controls or regulates the gastrointestinal system. So what are the candidate hormones? So in the previous video, we discussed about the primary hormones that meet that criteria, but there are secondary hormones, they meet some criteria, right? So that is what they classified as secondary or candidate hormones. Because some textbooks like in the Costanzo, they mention candidate or secondary in the Guyton, right? So various terminologies, all are same, right? And also these candidate hormones or secondary hormones, mainly the motilin, somatostatin, vasoactive intestinal peptide, and gastrin releasing peptide bombesin. And histamine, it is a peptide, it is not really hormone, but it's very important regulator of gastric acid. All right, so the motilin, the first hormone, by looking the name, you can easily identify the motilin, it having movement, kinesis, right? So motilin is a 22 amino acid peptide. It is not a member of gastrin or CCK family or the secretin glucagon family. So it is mainly secreted from the upper duodenum during the fasting state, all right? And the motilin is believed to increase the gastrointestinal motility, especially to initiate the interdigestive myoelectric complexes. All right, so in this picture, you can see all the various the cells, they release the hormones and the motilin from the M cells of the duodenum, especially during the fasting state. So what are the physiological functions of motilin? The effects of the motilin, mainly it stimulates the gastric and small intestinal motility, causing undigested food in these regions to move into the large intestine, right? So we don't want to keep the food in the stomach or duodenum or jejunum for longer time, right? So once you are done with the absorption of nutrients and the secretion, absorption, you have to propel these waste product into the rectum, right? So that is what the motilin takes the play to move this chyme into the further away from the small intestine. And also that's what when you have the fasting, you can see that noises, your abdomen make a lot of noises. Those sounds, we call it as a borborygmi noises. So like growling, rumbling sounds. So especially when you do the meetings in the silent room, it's annoying, sometimes makes it can you can hear those noises, like it makes every 90 minutes during the fasting state these noises caused by the bottle. All right. And also usually absorption phase occurs the first 4 hours after meal, then after 4 hours you go into the fasting state. So next one is the somatostatin. The somatostatin, maybe you guys heard like maybe in the neurosystem, the somatostatin is the another hormone. So it's mainly from the pancreas, the gastrointestinal tract, and also from the nervous system. The 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 somatostatin is the 36 amino acid peptide. It is mainly released from the D cells. Okay, it is mainly released from the D cells of the islets of the Langerhans of the pancreas. So in response to carbohydrates, proteins, and lipids. So you can see in the picture, this is the endocrine islets. You guys learned this one in the endocrine reproductive system. Like alpha cell secretes glucagon, beta cell secretes insulin, right? So delta cell secretes somatostatin, and the polypeptide, that is the another polypeptide cells in the pancreatic beta cells. So, and also the D cells not only in the pancreas, this is also present in the stomach and intestine. And the somatostatin, it is release is stimulated by mainly increased gastric acid. So that means there is a decrease of pH, that means acidity, and blood glucose, secretin, and increased VIP, increased fatty acids in the duodenum, that stimulates the release of somatostatin. And also, what is the primary function of somatostatin? So we can call this is the brake, right? So this is a universal off switch. So whenever you have all these hormones are increasing, so body is a control, the switch off mechanism to calm down all these hormone release to reduce the load on the gastrointestinal system. Somatostatin is a universal inhibitor of all this hormone secretion. Like it decreases the gastrin and decreases the histamine, decreases acid secretion, decreases glucagon and insulin, cholecystokinin, secretin, vasoactive intestinal peptide, and gastrointestinal motility. And the next one is the vasoactive intestinal peptide. So by see the name vasoactive intestinal peptide, so that is a mainly the vasoactive intestinal peptide. So vaso means vessel, right? So whenever you have the, it is mainly stimulated by whenever you have intestinal wall distension, then the VIP is going to secrete it. So especially uh, by the distension from the food or parasympathetic vagus stimulation, right? So acetylcholine mediated. So this is a source mainly parasympathetic ganglia in the small intestine, gallbladder, and GI sphincters, and released by enteric neurons. So especially the stimulus, the distension, vagus stimulation, that is acetylcholine, muscarinic receptors, right? And the distension, that is a local reflex. So enteric nervous system activation, and that causes the movement and relaxation of the gastrointestinal tract. And the vagal stimulation, that may cause parasympathetic acetylcholine input, that increases the VIP neuron 5. So which one is the inhibitor? So opposite to parasympathetic, that is the sympathetic is the inhibition. The epinephrine, that suppresses the VIP action. The next one, what is the physiological functions of vasoactive intestinal peptide? The first one, it may cause smooth muscle relaxation. So it relaxes the lower esophageal sphincter, stomach, gallbladder, and intestinal smooth muscle. Overall, it decreases the contraction, increases the relaxation. That is the vasoactive intestinal peptide. And also, we know that that is the decrease pH is a stimulant for VIP. So that's what it inhibits the gastric acid secretion by directly decrease the parietal cell activity or contributes the reduced gastric secretions, and increase the intestinal pancreatic secretions. So that increases the water and electrolyte secretions, especially into the pancreatic juice, bile, intestinal lumen, increases the pancreatic enzyme secretion. And also it inhibits the intestinal absorption. So the net effect, the vasoactive intestinal peptide, more secretion. There is a lot of secretion, the fluids and water, less absorption. So that promotes the flushing of the lumen. So it's like a washout of the all the gastrointestinal tract, like a protective mechanism, right? So you don't want to carry the waste material for longer time, right? The anti-inflammatory and tropic effects, it decreases the gut inflammation, increases the proliferation and repair of intestinal epithelium, and also stimulates the somatostatin release, so that activates the delta cells, pancreas, and releases the somatostatin, decreases insulin and glucagon, so indirect the metabolic actions. And in clinical application, because once you know the physiology, then it is easy to apply in the clinical application. So in the GI infection, we know that the VIP increases the secretions and water. So that causes the flush of a lot of pathogens. Whenever you have infection, you have more VIP stimulation that flush out all the pathogens. So because of the increasing secretion motility, and also it increases the epithelial repair. In terms of irritable bowel syndrome, there are some IBS phenotypes they may experience like diarrhea when they have increased VIP. There is a IBS constipation type also there, but so here mainly the IBS diarrhea type because of the, so here there is a slow elevation of the VIP that contributes to diarrhea and visual hypersensitivity and dysmotility, and also the VIPoma. So there is a rare pancreatic neuroendocrine tumor that may cause massive amounts of VIP. So that may cause, we know that VIP causes a lot of watery secretions. So that's got this syndrome called VDHA syndrome. All right. So this is a tumor in the pancreas. So that may cause a lot of VIP, and that may cause watery, diarrhea, hypokalemia, achlorhydria, right? So that means decrease acid secretion, increase alkalinity. Uh, so W means watery, D means diarrhea, H means hypokalemia, A for achlorhydria, B WDHA syndrome in VIP mode. And also there is a severe dehydration because you lose a lot of water in diarrhea, and also lots of electrolytes. So that is a classic feature of VOPOP. How to treat? So you have to give massive amounts of IV fluids, electrolytes to correct the dehydration. And also octreotide is the somatostatin analog, so that is the universal inhibitor. So that decreases the VIP. And also maybe the surgical removal of tumor and the anti-neoplastic or targeted therapies to manage the VIPoma. The next one is the bombesin. So bombesin, also known as gastrin releasing peptide, so GRP. So that is the vagus mediated releaser of GRP. The bombesin is a neuropeptide with multiple functions. It's mainly stimulated by or released from the parasympathetic vagal nerve fibers, and also bombesin acts as a paracrine hormone on nearby G cells to release the gastrin, right? So gastrin we discussed in the previous video. So that is why the bombesin, also known as gastrin releasing peptide GRP, and also it is considered as a neurotransmitter, and also the GA serves as a tumor marker, especially in the small cell lung cancer and neuroendocrine tumors and gastrinoma. And also the bombesin mainly stimulates the gastrin release. It strongly increases the gastrin secretion from the G cells that leads to increased gastric acid secretion, and stimulates the pancreatic enzyme secretion that enhances the exocrine pancreatic output and works synergistically with the cholecystokinin. And also the bombesin increases the GI motility. So that's like a pro-motility effect, and also acts as a neurotransmitter in the enteric nervous system that modulates the gut-brain signaling and influences the satiety and feeding behavior. We are going to discuss more detail about the satiety and feeding centers in the next video. And also it acts like a satiety hormone, right? So you don't eat much, it decreases the appetite, you feel satisfied. That is a satiety. All right, so next important one is the histamine. The histamine, mainly the source of histamine is the enterochromaffin ECL like cells in the gastric and gastric fundus. The main receptors, H2 receptors, these are GES mediated cyclic AMP. You guys can watch, I have YouTube video on how to remember G protein coupled receptors so that you can easily identify all the receptors, what is the second messengers, right? So the MAT2s are inhibitory, I have one M&M, and the rest of all the receptors are GS. Okay, so it's just a 5 minutes video, just you can watch that, you will be fine with all the medication second messenger receptors. All right, and the histamine also released from the mast cells, that is the H1 receptors. Okay, so don't worry about here, our target is the gastrointestinal tract, H2. All right, so H2 blockers like all the tridins, famotidine, ranitidine, cimetidine. So these guys mainly blocks the H2 receptors. We use the gastroesophageal reflux disease and the peptic ulcer disease, that is gastric and duodenal ulcers. and Zollinger-Ellison syndrome with the ulcer condition, we use the H2 blockers. And the stimulus, mainly the histamine, the gastrin, that is the from the G cells, and also the vagal stimulation via GRP that stimulates the ECL that releases the histamine, and acetylcholine indirectly the vagus nerve that stimulates the histamine. So what are the inhibitors? Somatostatin, it's universal inhibitor. The prostaglandins, PGE2, that inhibits the histamine release, and low gastric pH. So that's also inhibits the histamine so that it decreases the acid, right? So what are the actions? The histamine is a potent stimulator of gastric acid secretion, right? So that's what whenever, for example, in the clinical case, the patient is on H. pylori infection, but you are not sure whether he got H. pylori or not. He come to clinic, but he took couple of proton pump inhibitors, but you want to give the stool test for the confirmation of H. pylori. So in that case, if the patient took a PPI, so that you cannot test the patient stool sample until 14 days. Okay, otherwise the PPI interfere with the H. pylori testing, you may get the negative. So that's what during that period, so we put the patient on the H2 blocker that won't affect the results of H. pylori. So that's one of the important clinical pearl with H2 blockers. And also the histamine mainly binds to H2 receptors in the parietal cells that leads to increased cyclic AMP via GS receptor, so that increases the H plus potassium ATPase pump activity, right? So that is a proton pump. So that increases the HCl secretion. When you block this one, so you are going to decrease the HCl secretion. So this is the strongest direct stimulator of parietal cells, histamine. All right. The next one, the summary of what we learned in these hormones of these 5 secondary hormones. The first one is the motilin, that is from the M cells, upper small intestine location. What is the stimuli? The fasting state, and every 90 minutes. And primary action, it stimulates the gastric small intestinal motility, motility, right? And so why you need motility? So you have to push all these the food into from the proximal to the distal. And also it produces the migrating motor complexes, MMC, and also erythrin as a motilin agonist. It acts like a prokinetic agent, especially the patient like diabetic gastroparesis. They have less the peristalsis. In that case, we give prokinetic agent that enhances the motility, erythromycin. The next one is somatostatin, universal inhibitor from the delta cells, mainly in the stomach and the pancreas. The main stimuli is the acid, so the pH is the less than 1.5, and secretin, VIP, and the vagal tone. And also it inhibits the release of the gas, inhibits the release of gastrin, and secretin, cholecystokinin, VIP, insulin, all the secretions will be inhibited by somatostatin. So we can use the medication called octreotide, somatostatin analog. And VIP, vasoactive intestinal peptide, it is mainly released from the enteric neurons. So the major stimulus is the VIP, is the distension vagus nerve, and gastric acid, and epinephrine. So intestinal smooth muscle, yeah, distension, vagus nerve signals, and GI infections. So these are the major stimulus. And inhibitor, mainly the opposite is the epinephrine, the sympathetic. The functions mainly increases the smooth muscle relaxation and lot of secretion of water, and also decrease the esophageal sphincter contraction. And the pancreatic secretions also increases the intestinal secretions. The clinical application, there is a viopoma, the tumor in the pancreas that may cause the WDHA syndrome, that is the watery diarrhea, hypokalemia, chlorhydria. The treatment is the octreotide, somatostatin analog, and bombesin GRP, that is the gastrin releasing peptide. So this is the cells mainly from the enteric neurons. The major stimulus is the vagal stimulation, and the functions are increase the gastrin release, increase the pancreatic enzymes, and also tumor marker for small cell lung carcinoma, And the next one is the histamine. It is released from the enterochromaffin-like cells, ECL, and the stimuli mainly the vagal stimulation and the gastrin. And the functions mainly it increases the HCl production via H2 receptors. The target of these H2 receptors by many medications like ranitidine, famotidine. All right, the summary quiz. Pause the video each question, try to collect the correct answers. The first one, which are the acid reducers? You got this one, that is a secretin, gastric inhibitory peptide, somatostatin. Acid stimulators, gastrin, histamine. Motility stimulator, you see the name motility, motilin, cholecystokinin, kinesis means movement, gastrin. Motility inhibitors, somatostatin, gastric inhibitory peptide, somatostatin. You see the name that gives some meaning. Pancreatic enzyme stimulators, cholecystokinin, bombesin. Bicarbonate stimulators, secretin. Insulin stimulators, GIP. Alright, so these are the references, Costanzo and Guyton, First Aid, Trueland, Scholarly RX will be continued in the next video. I hope you guys learned something. Thank you.